But what I want to show you is that when we look at the blood of the Th2 cells, it is only the skin homing ones that are increased in atopic dermatitis in these very young children, not the CLA negative ones that you might think are seen and go up with atopic disorders. In addition, there's no marker of chronic activation in these young children, as you see in adults, and there's no evidence of circulating CD8 positive cells or CD4 or CD8 positive cells that express Th22, even though we've got a lot of that IL-22 in skin, or Th17, even though I'm not showing you this, but in fact children have a lot more overall of the Th17 expression in their skin. So I think this raises an interesting question of when does one see this increase then between the CLA negative CD4 positive Th cells, and how does that relate to the development of other forms of atopy? So it'll be very interesting as we continue studies to look at whether those kids who go on to develop allergic rhinitis or go on to develop asthma have a correlation temporally at that point with the non-skin homing Th2 positive cells in their blood. And why that is important is because if that's the case, there may be a window of time where we may be able to prevent that progression to these other forms of atopy if we can catch it. And we now have ways to suppress Th2 specifically. Now I want to spend a little time talking about the concept of barrier and the importance in these atopic disorders. So it's been known for a long time that you can create models by tape stripping the skin of mice, putting an antigen on like ovalbumin, and you get something that looks like atopic dermatitis. You can then take that same mouse and expose through the nasal area to, or through the airway, through to ovalbumin or whatever antigen you've put on the skin, and you create asthma. So that patient's already sensitized, and you go on and you can, not patient, the mouse, to asthma. So this has been a model of the atopic march. Fascinating work that's just come out from Ireland in the last year or two, from Alan Irvine's group, where he is prospectively following a cohort, not a cohort with increased risk, just a general cohort of neonates through infancy now, and looking at the transepidermal water loss, which you can measure and is a great measure of the function of the epidermal barrier. So he's looking at this at 2 days out, at 2 months out, at 6 months out. And what he recently has found is that by looking at that 2-day-old epidermal water loss, if you find it's in the upper quartile, you can predict that the baby will have a 7-fold increased risk at 1 year of age of having developed atopic dermatitis. And that 2-day measurement is regardless of filaggrin status. Actually, if you have a filaggrin mutation, it doesn't really affect the transepidermal water loss till the 2-month and 6-month measures for whatever reason. And he found that the lowest quartile was protective. Now, in continuing to follow these kids, at 2 years of age, he's able to predict the development of food allergy. So that 2-day-old transepidermal water loss in the upper quartile, if you have developed atopic dermatitis, gave you an 18.7-fold increased food allergy risk. This is not food sensitivity. This is documented food allergy. And if you don't have atopic dermatitis, it still gives you a 3.5-fold increased risk of having food allergy just by having that abnormality in your barrier function. And that suggests that the barrier abnormality is very connected, that early barrier abnormality, very connected with the increased risk of atopic dermatitis, and may also drive a relationship between atopic dermatitis and food allergy. Our studies in that early patient population in skin did not show the filaggrin deficiency that we talk about all the time as being part of the atopic dermatitis picture and that we see in adults. Now, I will tell you that only 1 out of about 20 kids here had a filaggrin mutation that we could find, But nevertheless, you can see that the expression pattern compared to controls is not significantly different. But here's the adult. In both lesional and non-lesional skin, a marked decrease in the expression of filaggrin. And I could show you the picture as well of the immunohistochemistry with filaggrin stained, and it's the proteins there too. There's not a deficit. And yet, these were taken at a site where the transepidermal water loss was very high, 32. Now, normal is about 8 to 9 in that range in our hands. So we're talking about a transepidermal water loss, a barrier dysfunction, but not in the face of filaggrin. So that suggests that the filaggrin deficiency in adults may reflect chronic exposure to cytokines and Staph aureus, that the therapies that people are trying to develop now to increase filaggrin may really not play a very important role in the young child, but it also raises the question of what are the protein and lipid abnormalities beyond filaggrin that can cause this early barrier impairment and potentially finding new targets that are important in the very young. Now, speaking of the barrier and how important it might be then in prevention, I want to make sure that you're aware of some of the work that's going on right now to use emollients to provide an artificial barrier and try to decrease the risk of atopic dermatitis and the atopic march. Now, Eric Simpson teamed with Hyle Williams in the UK to do a pilot study, just a pilot study to try to plan for the big study. And in this pilot study, they wanted to see how well parents could adhere to either putting on emollient on a regular basis or not, and what they might choose. So they started a trial, small trial, randomized controlled trial, in which in the first weeks of life, by 3 weeks of age, in high-risk infants, that is with a first-degree family history of atopy, they asked the parents to at least apply daily full-body emollient therapy versus controls, which they really weren't supposed to put it on. And they actually gave them a choice, and as it turned out, for the most part, they chose the cream form over an oil or an ointment. And what they found in this preliminary study was significant data. At 6 months, the emollient, which was used on average 5 days of the 7, reduced the cumulative incidence of atopic dermatitis by 50%. And then there was another study in Japan where at 32 weeks, 32% fewer infants with emollient had atopic dermatitis, and they were supposed to start that in the first week of life. So there are larger prospective studies now in progress to try to further substantiate this, but also to take it farther and find out what's going on with respect to the atopic march. So I think that's very exciting. Well, let's talk about therapy a little bit and what's new there. Of course, we're trying to suppress the inflammation, the pruritus with anti-inflammatory therapy. Topical steroids continue to be the mainstay and will, for no other reason other than their cost. But how we use them sometimes can be very individualistic based on the patient, based on how we tend to do things. I'll tell you, in my clinic, no one gets the same course. You got to really individualize. But what we're doing more of is this aggressive therapy, like what we might call burst therapy. When I have a new patient who comes in, it can be horribly severe, and I will tell them for 2 weeks, occasionally I'll go 4, to use a class 2 steroid and just get this thing wiped out, stop this cyclic process, and then we can see what we need to do. Maintenance is the hardest part, but for many of these kids, if you just knock it out, they barely need anything. And then you can use, for just a few days, a stronger steroid and not worry about it, because we don't worry about it, using something stronger for a few days. So we can do this aggressive burst therapy. We can maintain, and sometimes that's just maintaining with emollients and hitting with a stronger steroid as needed. Sometimes it's dialing down to a lower strength, or sometimes it's what's called proactive therapy. And proactive therapy is actually FDA approved in Europe, but it's something that we're doing more here. It's a little tricky because each person may need a little bit of a different proactive therapy approach. But this is the concept of getting them under control and then continuing to use the topical medication on a regular basis in areas that are now clear or almost clear but recurrently flare. And this could be a medium-strength topical steroid. This could be a topical calcineurin inhibitor. But nevertheless, it's a concept that has shown overall a decreased total use of steroid, a decrease in potential toxicity. And you can look, for example, at the thinning of skin, and it's largely reversed. And importantly, increased compliance. You wonder how many of the patients we tell to use something twice a day actually do that. I think it's very hard for families. And compliance has been shown to be a major issue. I love the work out of Wake Forest showing with the stealth microprocessor in the cap how many times patients opened up the tube to put it on, finding overall a 32% compliance to the atopic regimen over a course of 8 weeks. And that greatest compliance was 2 weeks after the visit and in the 2 weeks right before the visit. So I think it tells us that we really need to spend some time trying to optimize compliance. We need to think up front about whether there's steroid phobia or topical calcineurin inhibitor phobia, of course, is there too with that black box warning, whether the timing that we've told them to use fits with the family's lifestyle, whether the vehicle is something that's acceptable to the individual. And I've had many children a lot of them have sensory issues. They don't like the feel of this, are really sensitive to that. And exploring what they like makes a big difference. I found a lot of kids, for example, who don't mind oil at all, but they really can't stand those ointments. So you got to figure this out because parents have to be able to work with a child and make that happen. And then to heed those preferences. The Wake Forest group has also shown, too, that it makes a big difference, it makes common sense, if you have the patient come back fairly soon after you introduce a regimen, especially for a new patient, so that you can really work with them to say, see, it works when you use it, that sort of thing, and you can get that rapport that helps moving forward. And I can't emphasize enough the importance of the education and having a written action plan go home. And now that we have, of course, electronic medical records, it's pretty easy to do some fill in the blanks and print it out and send it home. But we've all been in situations where we go someplace and we talk to someone and instructions are given and we totally grasp it. And then we get home and it was like, what did he say? So these written action plans are critical and should always be used. Just to mention about the black box warning, if you're using topical calcineurin inhibitors, which I, by the way, love if I can get them, that's always the big issue, you have to spend a minute talking about the black box warning, because if there's a black box warning, the pharmacist is obligated to tell them about it. And if you do not tell them, they probably won't use what you prescribe after the pharmacist tells them that it can cause cancer, especially in a child. So taking a minute to say, the pharmacist is obligated to tell you about a black box warning, so I want to tell you about this, and that in the last 15 years plus since it's been out, there really has not been any evidence of this. What was concerned originally as a theoretical risk, and I talk about it. And as you can see up here, although actually studies have suggested an increased risk of lymphoma, particularly with more severe atopic dermatitis, there's not been any correlation with their use. And there are now continuing ongoing studies with large numbers of children, one that was started by the folks who made tacrolimus and one from pimecrolimus. And so far, there's still not one shred of evidence of this lymphoma risk, which was theoretical, or a non-melanoma skin cancer. So I think we can use these with comfort.